So dear guests, dear colleagues, thank you so much for finding time for us and visiting us here, neglecting and overcoming all this horrible traffic. And we hope to have a fascinating lecture today. Our guest, so just one more thing, we have also online participants from Armenia, from Yerevan, so greetings to them. And also some colleagues are participating online. So for them, during the lecture, your microphones will be muted, and after lecture, certainly you can ask questions and have a discussion. And it's my pleasure to introduce our guest, Urban Biden from Sweden. And I will tell a very brief biography. His sports. So he was playing ice hockey when he was a child. Afterwards, for 10 years, he was in national team of Sweden in sailing. And then he was Ironman competition. It means triathlon, 4-kilometer swimming, 180-kilometer bicycling, and marathon running, 40 kilometers. So, and his biography in the science is not less impressive, and maybe a bit more. He was always in the frontiers of creativity and intelligence, and I hope very much that his lecture today will be really impressive one, and will be very practical too. So, stage yours.
Thank you, Irakli, for these nice words, and also thank you very much for inviting me to Georgia for the first time. It has been very nice to be here. We were visiting the old capital today and the monastery close by, so it's really scenic view. And I think it will be very interesting to discuss this topic today, because it happened so much this year in the area of Alzheimer. So it was a publication in JAMA in January this year that was really the trigger of things going on. And at the same time, 2 new pharmaceuticals, one from Lilly and one from Biogen SI in Japan. These 2 have been launched in major markets all over the world, and it's they call disease-modifying drugs, and it can make a big difference for Alzheimer patients. So let's start. So we have a huge dilemma coming up here. So people are thinking that we will have 3 more number of Alzheimer patients in the future. Of course, the aging population is one of the drivers, but it's not everything. So we have a big hurdle what we have to take care of. And maybe the diagnostic can be one of the cornerstones, of course, together with the new pharmaceuticals. So we have developed a new test, what is called pTau 217. This is the one we will talk about, but we will also give you the full picture, what type of diagnostic we have today. And this test, just to say, it's approved by FDA with all these constraints. And the trick behind this was that the colleague, what I'm working together with, Mr. Professor Hans Friedman, he was clever enough to buy validation material from Australia. So he bought 400 healthy control patients with PET scan and with blood, and also 150 Alzheimer confirmed patients with PET scan and with blood. So these have been the materials that was going through FDA very quickly, and now we also have reimbursement for this test in USA. So let's focus on the overview, and as I said, this JAMA article was really the driver. And the highlights of this is that it's higher accuracy, and it's much more convenient with a simple blood test that you are sending to all these collection centers here around the company in the city here. Comparing to PET scan, PET scan is the golden standard, and if you give a picture to a GP, 6 out of 10 he or she can make some decision on. And if we give it to you who are specialists in neurology, it's 7 out of 10. So it's 60 or 70%. This test is giving 95, 96% of accuracy. And CSF is also a really good test, but it's very inconvenient for the patient to take this test, even if the material is very good to make analysis from. So this will be the discussion today, the overview of the disease, shifting the paradigm, and the number of fluid biomarkers we have, and also a little bit of our other immunology testing that we have available. And the hallmark in this disease is the amyloid plaques and also the intracellular tangles. And these are the things what we are measuring. And now this is a picture from the medical school that you have already passed, all of you. But we have cognitivity unimpaired, so that is a healthy one on the right corner. And after that, a mild MCI patient can go 7 years without any symptoms at all. 2 years it comes into the mild Alzheimer's disease, and 2 years it comes to the frontal lobe, and in the end it's spread all over. And these are the development what the Alzheimer's patient is going through. And unfortunately, 50% of the cognitive impaired patients don't have a diagnosis or is misdiagnosed. And providers, that could be you here in the room, are unmotivated to diagnose Alzheimer's disease because of perceived lack of accessibility of the diagnostics. It's very hard to get expensive PET and CSF. And treatment options, as we know, is very limited. And for that reason is also the motivation to take this. And this is leading to significant delays. Patients avoid seeking diagnosis due to cost and the stigma, what we will talk about later, and fear of lack of treatment options. So that means it's just 8% that are diagnosed in early stage. And this is the best time to get the diagnosis because you can do something about it with lifestyle changes and some pharmaceuticals. And this is the good news on top here, that Alzheimer is not longer untreatable. And lifestyle changes play a significant role now when you get this early. And also, as I said before, that early intervention is always much better than doing it in the late phase. And how to facilitate this diagnostic landscape. So I think the role what you have as specialists is to educate the GPs in the country to find this patient very early, because when they come to you as specialist, it's normally too late. And we are running 3 big primary care studies in US now to see how this will work. So that will be interesting data, because to come in earlier with the treatment and all other actions will probably play a good role. And broadly accessible self-assessment with techniques and blood-based biomarkers, and improve the screening so the right patient get the right treatment. And let's go into what we have discussed, So what we have is the amyloid. This is the tau pathology and the neurodegeneration. And detection methods is the PET scan and also tau PET, that you maybe is not familiar with, but also this structural MRI. Or what is CSF different, the ratio, alpha 4240, and the CSF pTau 181, or 2 tau with CSF. So this is the landscape today. And the golden standard here is the PET scan. And as I was talking with one of your colleagues here, it's interesting if you have something what have 95% accuracy, and after that you should compare it with a gold standard what have 60% accuracy. It's a big challenge in this. CFS testing is cheaper than PET, but patients still face discomfort. And blood test improves safety, accessibility, and affordability. And here is another picture from your medical school showing what is happening in the brain with a GFAP here, that's a marker, and also amyloid to check in the end, and the neurodegeneration effect also on the neuron. And how should an ideal blood biomarker look like? We like to have something what is accurate and reliability, easy to collect, as it is in all the centers that you have here around, facilitate the early detection, and clinical actionable, widely accessible, and resource efficient and cost effective. And as said, the threshold to get a test approved is that it should be over 90% accuracy. And this test, the one that we are offering here, had 95–96%. And as said, that the Alzheimer Association and the National Institute of Aging, the threshold they are asking for is the 90. And never could have the most thorough pTau 207 clinical validation studies conducted. So we have got from patients 1,100 from memory clinics, and we also have 400 healthy controls with PET scan and blood, and 150 pathology confirmed samples. So this is our treasure to when we are developing new methods. We can go with this material and see, and we can get approval very quickly. Yes, so this will be, I know that the people who work here in the laboratory, they like to see such nice pictures of machinery. So the first machine we used is from Quanterix. It's the name HDX analyzer, and the method is SIMOA, what is called single molecule assay. And this one is measuring on picogram level per liter. So it's 3 more zeros before it comes a number compared to methods what you are used to before here. But we also use one machine from Fujibiru that's called Lumnipulse. I don't know how to pronounce it exactly. But that one is much quicker. This one takes quite a long time to run. So to use different cutoffs, below the lower cutoff there is a high level of certainty, 95 to 95%, the rule that MCI is caused by amyloid pathology. And the upper cutoff say that more than 95% certainty that the patient has this. And that creates a very clear answer. So it's good to have clean cutoffs, so we know exactly what to say to the patients. And for this test, we have this 0.32 nanogram per liter, or test result over 63. And between here, we should talk about the intermediate situation. But it can look like this. Your patients here, you don't know exactly which one. You take your blood, an estimation of the underlying pathology, and after that, the patient is divided in these 3 groups. And this is what we recommend to do. And the tricky thing is, of course, how we should treat the intermediate cases. If AD is still suspected, refer to a specialist and may order PET or CSF. Or 6 to 12 months, follow up with patient and take a new test to see where the level is. And what is interesting is that we can now see Alzheimer's disease like up to 20 years before the first symptom. And that's it's really scary also. Today, it's more or less too late when we see Alzheimer in the patients. And for that phenomena that we know so early, that put the patient in a very special situation, that if you have a healthy person, maybe 55 years old, and now you can tell that he or she is maybe have a prognosis of Alzheimer in 10, 15 years. How to deliver that message? Is it good or bad? Of course, if it's not delivered in a professional way, it can create anxiety for the patient. And so for that, and even worse, suicide and other things could also come up if the person has someone in the neighborhood who have going through Alzheimer's. So for that reason, we have developed a special program to educate people, probably here in the laboratory, who can wrap up this answer to give a positive message to the patient and see the future in the situation he or she will be in. So it's called Brain Scan, this program what we have developed, and it's a 36 hours online training for a physician to take this, and after that he or she will be certified to give the answer on this, instead of just 0.34, and that can create such a dilemma for the patient. So Brain Scan is a program, and here is an example that we explain what the test is, and this could be read by the patient and the treating physician, of course. And in this one, we have your result was 0.26, and the cutoff was 0.47, and we say it's excellent, congratulations, and so on. So this is not related to some pre-dementia for Alzheimer. But there is some other measurement also. That's NFL is measuring the degeneration of the nerve cells. And in this case, you can see that increases where it's ongoing. It can be a car accident, it can be a stroke, or other things. So it's so many other things what is driving this. But together with other measurement, it can give some good information. And there is some caveats here also for using NFL in daily practice. And the other one here is the result. The result is high for your age. It indicates that you're likely to be some ongoing damage in your brain, which may come from a number of reasons. And for that reason, we ask to discuss with your treating physician. And the other one, what can be measured also, is the GFAP. I don't know if that is FDA approved now, but it's very close to it. So this is a research-only test, but we can provide that also from plasma. All these three tests I mentioned here is coming from plasma. But also, test result for research only, not be used just for diagnostic. Test performance should be determined by Neurocode. It has not been cleared and approved by FDA yet, so that's the note here. But I think together, these three will be very helpful. pTau 217 will say yes or no on Alzheimer, and these two tests will test the degeneration of the brain. So in this case, you see it's 200 nanogram, and it should be optimal range should be less than 78, and that's probably an ongoing inflammation in your brain. So this is just an example to show what we believe will come up with this test, because it's new data, and we can tell so much earlier that the patient is exposed for Alzheimer, and for that reason we also have to be very professional to deliver that answer in a good way to the patient. Okay. There is one more test that also can be interesting to hear about. That is the heritage of Alzheimer can also be followed up by ApoE genotyping. And that's not the high volume test, but we can also offer that one if you like. But you can see that epsilon 3, 4, and 2 have different impact of the heritage. CSF, I think you're very familiar with. You have can order that from the company here, and I think they are sending them to Germany at the moment. We have the full portfolio of CSF tests also, so if you start to send plasma, we could easily also include CSF in the cases that you like to have that. So here is how our portfolio look like. pTau 217 and 181 was the first one, but most specialists around the world say that it's enough to keep the 217, but in some cases people like to order 181 also. And the CSF testing is the ratio. amyloid beta 4240, total tau, and 181, NFL and APOL. And this is for the neurodegeneration portfolio, NFL and GFAB. So this is a picture we use in USA. It's like a commercial one, we could say. It's a different situation, but we are unique, broad range of plasma and CSF. And that means we are like a one-stop shop here, so you don't need anything more than we can do. We have extensive clinical validation of the studies of our tests, and we are the only clinical laboratory that have multiple plasma tests with different machines, and that means we have redundancy. If one machine is going down, we can send from Vancouver to Seattle or vice versa. It's just 1 hour drive between these places. And we have also extremely good relation with the global key opinion leaders. I know that Irakli was on the symposium we had in Dubai earlier this year, and he could meet the 5-6 most prominent professors in the world that collaborate in this area. So we have learned these methods from Gothenburg in Sweden, but we have developed it in USA and Canada to the next level by buying this validation data, what was have been necessary. So this is just the list, what we showed before. And I just like to mention, I'm I'm just 6 months into this area of working. So, and the area itself, it started 4 years ago with the first idea of this type of measurement. But this is the bread and butter portfolio, what we're working with, what we are one of the best laboratories in the world. We have about 20% better accuracy on our test versus the other is in Oxford one, another is in Barcelona for these rare diseases. But we can talk about that next time, but I just like to show the list of the main product that we are promoting before this tau. Yeah. Okay, I think that was everything. I hope you found it interesting, and maybe we should take some questions. Irakli?
Pleasure. Some questions?
Thank you very much. It's really impressive, and I think it's a nice way to help somehow our patients in the preclinical stage or in the stage of mild cognitive impairment when the patients, and it's maybe specific thing here in Georgia is that these patients also come to specialists. They are bypassing the primary practitioners level and get to the specialists directly, since they have these very mild cognitive problems like subjective complaints, and it's quite traditional to avoid the primary care gate, let's say. And may I have a few questions about this, your presentation? Don't you measure the ratio of phosphorylated tau 217 to non-phosphorylated? Because I read that this ratio is also very sensitive to detect the early stage of Alzheimer's disease.
I have heard about that during symposia, and I'm sure that a lot of research is going on. But now they say that it's maybe not necessary, but you can see all these ratios. It's still available, and if you like, but we like to promote to use just 217 now in the beginning here to detect yes or no. And as you said about primary care, that's an issue all over the world, so it's exactly the same. But we think if we should go with early intervention, that means the patient don't have any symptoms at all, but maybe there is some history around in the family. In this case, it's much better to go in early, but with the issues of telling someone who is absolutely healthy that in the future you are exposed for to be predominant for Alzheimer.
Okay, and the next question is about this amyloid beta 42 to 40 ratio.
Yeah.
You are doing this in the CSF and not in the plasma. Because I also, there is some data that in the plasma it has almost the same sensitivity and specificity and diagnostic accuracy as in the CSF.
I think it's on, yeah, you see here, we have on this paper here, in research use only, we have it in plasma also.
Okay.
Yeah,
Okay.
but soon it will come into the clinical.
Yeah, and this was a publication of the Lund University group of researchers. You probably know them.
Yeah.
There is one Georgian young lady.
Yeah.
I'm proud of that.
You
Sholena
should be.
Janelidze, who works there.
Yeah.
And they found that this ratio of phosphorylated with non-phosphorylated tau 217 combined with this plasma amyloid beta 42 to 40 ratio has maybe the highest diagnostic accuracy. This paper was published again in JAMA, but in July later on than this which you showed.
Yeah. Yeah, it was more clarity in the July version, but the January was the one what was trigger.
Yeah, it opened all these
Yeah.
windows.
Yeah,
Thank you very much.
thank you. Some other questions?
Maybe a practical issue. How much it is?
You should ask my.
So I have more technical question. Could you elaborate more on collection if there is any specific collection procedure, and also storage and timelines when patient get the result?
Yeah, we have very detailed how to ship and everything, but it can stay in room temperature for 24 hours. It can stay for 1 week in a refrigerator, and after that we have -20 and -80, and it can be defrozen and frozen in 5 cycles. So it's quite stable, and it can easily be sent on an ice block. So if Iraqi put it in a weekend bag and put ice block and send it with DHL or something like that, we receive it the next morning. So.
What about the timelines when patient gets the result?
It's about, let's say, 3 days when we get it into our laboratory, but it depends if now in the beginning when it's some few samples coming maybe from a big region, Iraqi maybe like to collect 10 or 15 or something like that, not send one by one. So it depends on the volume, but if it's going 2-3 times per week, it will be maybe 1 week, 2 weeks. But this is not an urgent issue to answer out on Alzheimer. So it's not like myocardial infarction or something like that.
So one more question, so maybe I missed this. So this normal range, so it's linked to his patient age?
Not so much.
Because one of you once mentioned that during this interpretation, that this result is not normal for your age.
No.
So it's linked to age or not?
the tau 217 is not so much linked to age, but the other two I was showing is more linked to age, the degeneration.
Mm-hmm. Okay, thank you.
Thank you for your presentation. My question is regarding the disease-modifying treatment that you just briefly mentioned, and we know that there are two monoclonal antibodies which are now used widely in the world. And do you have any data how this, how treatment with these drugs correlates with the level of pTau 217, and if it can be used as somehow a marker of treatment efficiency when treatment is started with these monoclonal antibodies?
Yeah, it's really impressive to see the clinical data from the pharmaceutical companies, and I'm unfortunately not representing them, but in general terms, patients get like 30% improvement, and that can be, some of these parameters go down to 0. But that don't mean that the patient are completely healed, but it looks very good, and the diagnostic will be very helpful for using during the treatment. So we are working together with these companies in some markets to have a sponsor test, so the companies pay us to perform the test, to use the treatment. So this test is before Irakli say it's in $100 range. 1 year of treatment is $25,000 for 1 year, and it used to be 2 years treatment, and after that the patient get effect in 5 years after that, in general terms.
Just to add something, few words. Maybe for the monitoring of the treatment effects, not the tau, but the NFL might be a good way to measure how effective is treatment. And it's used in different other diseases like multiple sclerosis. You measure NFL and you can assess the treatment effect by disease-modifying therapy in that disease, in multiple sclerosis.
Yeah. Sorry, I'm not an expert in the treatment, so but I think it will be very helpful to have easy access tests when someone decide. But I see in the country I'm coming from, Sweden, we have a very socialistic approach. So if a product should be approved, it should also be available for everyone.
Accessible.
Exactly. But in US, it's the opposite. You have these health insurances, so the rich people, they pay and they get the treatment immediately, but unfortunately it's not available for everyone.
And very brief question. So you make this analysis in those three measures in combination. So when we are sending the blood sample, we are awaiting the results for those three, tau, NFL, and FAB. Is that right?
If you ask Irakli for that, he will deliver that, but you have to put the cross. And as a starter, we think it's tau 217
Okay.
you should start with. But when you start to be more familiar to follow the patient's development, maybe in 1 year you will order all three immediately. I don't know.
So it's up to us.
Yeah.
Any other question? The audience, or maybe from virtual audience? And I'll just very briefly talk regarding pricing. So it will not be a cheap one in the beginning. What I can tell you, it will be in range of 1,900 lari, and more than 2.5 times its transportation cost. So there are technical pre-analytical problems. It should be frozen, and it means that the mailage is much more expensive. There's just 2 labs in the world which are performing these tests, and both of them are in USA and Canada. So it's much more expensive than mileage to Europe. And we have bad experience in pooling the samples, because patients, even in the case if it's not necessary to have results as soon as possible, they prefer to have results as quickly as. So we are not going to pool the samples. We will mail them, even there will be just one. But in case if there will be series or many samples, the price will drop dramatically, depending on the number of samples. The second thing is that if you are ordering many tests from one syringe, one probe, the first one is the, let's say, trigger of the price, and the others will be much cheaper. So if they are included, so if the sample is already delivered in the lab, then additional tests will be performed for lower price. So the biggest challenge currently is to mail the samples. Certainly it needs many things for customs and so on, and so that make it expensive.
And I can say that our aim is to be on the lowest price in the world from our labs in US. So as Iraqi said, that if we start to get some volume and get used to this, it will decrease dramatically. But yes, this is the hurdle here. Exactly. Highest quality and the lowest price. It's like IKEA.
Any other question?
Are you going to provide specific tubes or collect the samples or not? Tubes for collection. Is there specific?
What is called the violet EDTA
yes,
tubes.
yeah.
You send, and after that we spin them and make plasma, and after that put it in special vials.
Okay, now it's clear. Thank you.
So there's, we personally in our lab are using Sarsuit. So we are using just highest quality science. There are not just Sarsuit, but other 3 or 4 companies which are acceptable. We have also bad experience with syringes which are produced in China or so they are not always reliable. Not all of them, but it's quite a challenge to pay such a big money and such price, and to have this material, wrong material due to low quality syringes. And in our case, certainly you can get this from us, the syringes from us too.
Some questions from the back of the room.
I see Duda was raising hand.
I don't have any question because he had a neurology specialist, but I could say thank you very much for the very, very interesting information, and we hope we'll have some samples to send really.
Yeah.
And after the results, I think it will be some pushing facts that will grow and grow these tests in future. We will see.
Yeah.
And we hope that our Armenian colleagues will join this process very active. They are online now, yes? Thank you very much.
Thank you. And you can also raise question in your local language, and Irakli can translate if it feel more comfortable. Language should not be a barrier.
Just for information, we have already 2 answers, and there's a challenge. To whom should we give results? To patients or to doctors? Are the patients willing to to share the results to doctors. It's the topic what we have already, and so that is a way. If somebody else wants to participate in this 36-hour program, how to deliver these answers, we are glad to have some.
We have a link what I can send to Irakli about this education. It's 36 hours online, but before you just open the door here with the test, I think you should think it over before you just give the hard facts so someone, I think, in the surrounding should have this education to wrap it in a package that is easy to digest and giving some hope for the patient, even if the results is not looking the best.
I missed the point. What kind of challenge it is?
It is to whom should you give, how you give the answer, to whom you can give the answer, if it is positive one.
You mean from lab to whom or?
To patient or to doctor?
If this test is ordered by doctor.
That's the question. By doctor or by patient?
It should be agreed beforehand with patients that I'm sending your tests and I will take care about your treatment.
In case of genetic test, you have to sign the special document.
Do you have this kind of regulation to sign something?
Here in Georgia, not. But question
No.
is,
In US, it's going both direction. Sometimes straight to the patient, and sometimes to the treating physician.
But if the patient has some cognitive problems, anyway, it should be provided to care partner, not to the patient, right?
Yeah, but sometimes it's the relative who is ordering the test. So it's not often the patient himself or herself.
If the relative or patient orders this test independently from physician, I can understand that the results can come directly to the patient. But if it's doctor who ordered this test, I think it should be discussed before sending the test with patients. That first of all, maybe you have to ask for consent from this patient.
Yeah.
How can you use this test after you have result? But I don't think that it might be kind of problem here. Do you think so?
actually, the one case, we have just two cases. We have done it for free just to have the results. And one was positive.
And another was negative.
And the patient is demanding to have an answer. But the order, it was ordered by the doctor.
By physician.
By doctor. So
Very interesting, you know. It's,
Officially, who will order, he will receive the answers, yeah?
should yes.
yeah. But there are no regulations here.
No.
In this case, you can
sure.
you can do as you think yourself. Because if there are no regulations, you can receive this. But if patient asks to do that, probably
It's easy.
it's
In
easier.
this case, it was cognitive functions.
No, in US, we are selling special packs, lab that you take, you pay with a Visa card or something like on the net. Not that you get home a package, and that package you go to the outpatient clinic and take the blood,
Yes.
and the doctor send it, but we give the answer straight to the patient.
Okay.
And in this case, we are wrapping up the answers in the way what I explained.
That way,
Yeah.
you show. I think for HIV that is something you have no right to
Declare it.
no, for physicians it's not. They are not allowed to disclose it to third parties or even to colleagues. There is no, you have no consent from the patient.
Yes, sir.
Is that right? So you're also doing HIV tests here.
Yes, it's,
You are giving it directly to patients or to physicians?
We are giving to patients too, yes, but we are not allowed to hide it. So the result should be documented
I see, but you send these documents to physician or to patient?
to patients. In case of patients have no cognitive problems mainly. So in case of Alzheimer,
Yeah, this is quite a complicated ethical issue. But since there is no regulations, you can be more or less free to disclose the results to doctors or to doctors and to patients.
I don't like to make you afraid of doing this test, but I think it's good to just take a circle around and think how the result should be handled. So, but if you have done that homework, I think it will
We just simply just the one question to patients before you are sending the test. Would you like for me to be available about your test results? Because I will take care of your treatment, and the patient says yes, and I'm sure that in the majority of cases the patient will say yes.
Yeah.
So we can handle this easily.
Quick question. So do you collect additional information for the patients like family history or disease duration,
Yeah.
age of onset?
We have a request form with all this type of question that is very helpful for us when we are answering.
Even some clinical information, what kind of memory problems, and it's quite a big checklist.
Yeah, it's quite a big.
You have to tick and write something.
It will be translated in Georgian. It will be down. You can download it.
On the lab website.
Yeah. Yes.
Okay.
If there is any core diseases or chronic diseases which might cause
The audience in the web could not hear you.
First of all, thank you for comprehensive overview. If there are any chronic or other diseases which could cause a false positive result of this test?
On NFL, yes. On GFAB, yes. On 217, no. So I think the specialists know, but where is the substance? What is coming out from the brain is unique. And if you find that in the bloodstream, it's the only place it can come from. It's up in the brain. So that it can't be produced in another way. And if we find small quantities, it's for sure coming from this type of disease.
Do you plan to have this finger test for in the future? Point of care.
Yeah, we have a dry spot program going on, but we need a certain volume of plasma as a very new dry spot kits for plasma, what have been launched in US recently. But probably we need some more volume for this than this can produce, but for sure it will come. And that would be even more convenient. Yeah, and it will be easy to ship a dry spot in a normal envelope and not with ice.
It will reduce price dramatically.
Yeah. So it will be a meeting in Spain, I think, next week. Maybe some of you will go in this area, and we have a meeting with the specialist of developing this dry spot equipment.
There are no questions, and I want to cordially thank you for attendance and for your time. And thank you, Ruben, for a fascinating lecture.
Thank you very much, and it was nice to come here. maybe we can meet in 1 year ahead and see what have happened. And you have much more experiences than I have. Thank you very much for inviting me.
Thank